Okay.
Perfect. I always wondered what would happen if you said leave meeting, like if the lecturer just like, nope, I don't agree to these rules. Anyways, nice to see everybody. I appreciate you inviting me to speak. Jeremy Husted's the name. Addiction treatment's my game. It's this week I've been on call overnight, so I'm very little sleep. I'm running on Red Bull right now, so apologies in advance, but hopefully this is a good presentation. So I'm going to start sharing slides and we'll see what happens here. Coming through okay, and I'm going to try to make sure it's not the presenter view. It's probably the presenter view, so is that looking okay now? Okay. Awesome. All right, so again, name's Jeremy Husted. I'm not an English major. I was biology and I hated English. So the title of this is MAT for opioid use disorders, why we treat the way we do. I don't know if that's proper syntax, but to try to articulate what we're getting at. So I think sometimes it can feel a little bit like a black box of why we do certain things in medicine. Why are we treating in certain ways? I know I've had a lot of questions over the years about why do we do this for that, or why do we prescribe that way? And hopefully this gives you an opportunity to understand sort of from a clinical perspective, from a physician's perspective, why we end up treating opioid addiction the way we generally do now. All right. So my disclosures are, I don't have any disclosures. I'm not connected to any entities. I have no commercial interests. I have no pharmaceutical ties in the past, present, or future. So residents that have worked with me know that sometimes when I go to meetings, I'll actually antagonize the pharmaceutical companies, like call them out on some of their nonsense. I had a presentation yesterday and I thought one of the health insurance people was going to attack me. It's kind of interesting because, I'm not afraid to sort of say it the way it is, for better or for worse sometimes. But I don't think I have any reason to say something that's not true. I've always felt like doctors shouldn't have a vested interest in prescribing certain medicine. You should prescribe it because you believe in it, because it's the right thing to do, not because you have stock options in this company or that company. So hopefully it's a pretty neutral view of these things. So I work at WVU. I'm an assistant professor. I do a lot of different things, research, see a lot of patients. I've done a lot of lecturing over the years. Treated lots and lots of people since when I was in medical school, 2013. Currently work with Laura doing the IOP program. Also do research. Have run the inpatient dual diagnosis unit, have worked in residential programs, detox units, just about any place that you can get buprenorphine or other medicines. I also serve as the president of the West Virginia Society of Addiction Medicine. So that's the state chapter of ASAM. If you're all familiar with ASAM, it's a pretty large kind of physician-led group on addiction. So I always like to say, so 3 topics you want to avoid at dinner. You're having your little dinner party. So number 1 is politics. And certainly we have enough of that going on right now. So we don't talk about politics with the family. We certainly do not talk about religion, the family. And of course, we don't talk about MAT with the family, because it's a great way to get people upset pretty quickly. So I kind of fully acknowledge that it's not always the easiest subject to talk about, but it's definitely worth talking about. So let's take a pause. So anytime you discuss addiction treatment, but specifically treating opioid addiction, people generally have their own camps. I know I have over time. So in medical school, didn't really have any clue about it. And when I started medical school, is really at the beginning of the really fentanyl, the surge in fentanyl in the early 2010s. And so I didn't really understand what it was about. And my opinions changed over the years. So it went from like, this sounds really bad, to, oh, this is perfect, to it's not good, it's not bad, it's somewhere in the middle. It's for the right patient, it's appropriate. For most people, it's appropriate, to put it that way, but with caveats too. So everybody has their own experiences with patients or your clients, whatever we want to call them, and what they've seen work and not work. And all these experiences are valid. So, if you've seen a bad outcome, somebody on medicine, that I'm not here to say that didn't happen, because it did. So our experiences are all valid. and none of us has a full picture on treatment in general. So they're all valid, and I would just challenge everybody to keep an open mind about it today. We all have things to learn. I certainly have things to learn about it, and we'll try to do so. Has everybody here heard of the blind men and an elephant? Is anybody not familiar with blind men? Jay, do you know about the blind men and the elephant?
I'm going to say no, but to enlighten me.
All right, we'll enlighten you. So, so I stole this from Wikipedia. No shame there. Wikipedia is decent, but this is an old proverb. It's kind of interesting, and the whole idea is that you have blind men or blind prophets in a town, and somebody brings an elephant around, like an elephant just shows up in town. So the blind men go to check it out, and they can't see it, they can touch it, they can hear it. So their experiences, depending on where you may touch the elephant, is going to be very different compared to the other blind men. So, for instance, a blind man touching the side of an elephant might feel like it's a wall. Touching its tusk, it might feel like a spear. Its nose or its trunk, it might feel like something else. So all those experiences, all their descriptions are valid, but none of them have the full picture of what an elephant actually is because they can't see outside of it. I sometimes liken an elephant to addiction in general, and the people that suffer from it as being like stepped on and crushed by it. So addiction is a powerful beast, and again, your experience might be like this guy, whereas mine is more this or that. And again, they're all valid, but we all have an incomplete picture. So realizing that we have our own, limitations on our understanding. So the objectives of this talk are, one is we're going to talk about the disease model of addiction and how that guides clinical care. So fundamental to the idea of treating it is that it is a disease and it's a treatable disease. So it kind of, if that understanding is not there, then nothing else really follows. We'll talk about the medicines that we use to treat opioid use disorder. And lastly, we'll talk about new advances in the field, including now we have injectable medicines, but also too that the Department of Justice, the DOJ, views addiction as a protected disability. So that's a fundamental change in the way that we approach this compared to even a year and a half ago. So addiction being a treatable brain disease, this is from ASAM, again, American Society of Addiction Medicine. So addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry characterized by one or more of the following. So inability to consistently abstain. So people will continue to use drugs despite bad things happening to them. So they're trying to stop, but they find it difficult to stop. Impairment in behavioral control. So when people are using, they do things that they normally would never do. So they engage in activities that they wouldn't do when they're sober. They act differently. They feel differently. C for craving. And again, not just sort of, I could go for a cheeseburger today or a milkshake, or I'd love to go do this or that. More like an intense desire that an obsessional thinking. So imagine being trapped in the desert and you haven't had water for a couple of days and your brain is saying, you better get something to drink or you're going to die. That kind of craving. D, diminished recognition of problems. So when people are using, around them, things are falling apart. You see some terrible things happen, including, where it might come to the welfare of your children or your own health. You have some horrible infectious disease that you've gone on, or you've had multiple overdoses. However, people from the outside, at least looking in, don't seem to recognize that they're struggling. Lastly, dysfunctional emotional response, or E. So people's moods change when they're using. So people that have never been depressed before are depressed. People who don't have a history of psychosis suddenly are getting psychotic using amphetamines or cannabinoids. So your emotions change when you're using. You're a different person, basically. So we won't go into it too much, but in the brain, the idea is really, when we're talking about addiction, it's a brain disease. So it affects different areas of the brain, but the primary areas of the brain it affects are really the parts that are involved in reward, and basically the part that anytime that you do something even mildly pleasurable, like hugging your child or taking a drink of water, or again having a nice meal, or even getting out of the cold and finding a warm spot, that's the area of the brain that gets hijacked from with addiction. So typically we blame the nucleus accumbens and dopamine. So I always encourage people not to think of addiction as a disease of intelligence or logic. So, it's not as a disease that if you're smart enough, you can avoid. It's a disease of kind of more primordial areas of the brain parts of the brain we don't have much control over. They get hijacked essentially. The reward centers that are built in all creatures, basically. Uh, it's some of the most intelligent people I've known are the ones that have struggled the most with substances, which again, if it was just purely a disorder of intelligence, you would never expect anybody that's intelligent to struggle with substance use, but they often do, not worse. When people use, they have cycles of relapse and remission. We obviously like the remission, we hate the relapse, but relapse often accompanies addiction. Unfortunately, the disease is often progressive and fatal, so people will die from this disease, and there's different ways that people die. We typically think of overdose, but there's plenty of other ways. The idea of containing versus curing addiction. So I would love to say that medicine has got to the point where we can fully cure it, and believe me, we are working on things to more or less try to cure it. But as of right now, the most we can do is essentially contain it. And you could argue that most diseases that are treated, whether it's diabetes, hypertension, even cancer, it's more of a containment versus a full-fledged cure. Oops, sorry. As a physician, the two goals that I like to put forward, what I focus on is, one is keeping people alive, and two, increase the quality of their life. So there's no sense in just keeping people alive if they're miserable and don't get back some of the things that they lost. So one is, I don't want people to die, because there's always hope until someone's dead. So keep people alive, and number two, help them get back some of what addiction's taken from them. Because honestly, addiction is suffering. It's not a pleasurable experience as much as, there's times where maybe you feel good, you feel happy. Most of their life is misery, and it's not a life that I would wish on anybody, even my worst enemy. So when we talk about addiction, we consider it substance use disorders. It's kind of a diagnosis we own. I will say substance use itself does not necessarily mean substance use disorder. So if I drink alcohol, say twice a year, that does not mean I'm an alcoholic. Even perhaps if I did cocaine a couple times a year, that does not necessarily mean I have a cocaine use disorder. There's more to it than that. Typically, you see recreational use develop into more at-risk use, which develops into full-blown dependency. The idea that using a drug one time, you go from never having tried it to full-blown dependency is kind of naive. It typically is more of this progression. Now, I will say I've had some people that sort of sped this process up pretty quickly, and they went from I use a couple times to full-blown dependency rather quickly. But for most folks, it develops over time. So it's not a disease that suddenly you've never been using and then your brain has changed in a week. It's more of a development where your brain changes, your emotions change, your responses change, and then most people don't seek treatment until it's really taken over their lives. When we say something is a disorder, it has to cause some kind of clinically significant distress or impairment. So in some area of their life, it's causing problems. It's not just the use in total isolation. It's also everything that goes along with it and how it affects our lives. When someone is actively using, keep in mind that as doctors, we will try to avoid diagnosing them with other problems because they often share similar symptoms. So for example, if somebody's using a lot of meth or PCP, they'll look pretty manic. And I always say you could take probably the most normal, boring person out there. If you give them enough methamphetamines, keep them up for enough days in a row, they're going to look pretty manic and pretty sick. I guarantee you that. Synthetic marijuana, high potency THC, that can certainly cause psychotic symptoms that look like schizophrenia. Sometimes it can actually later on develop into full-blown schizophrenia, even when people stop using, which is a bit scary. And then, of course, alcohol, benzos, you do enough of them, you'll look pretty depressed. All right. So I like to compare sometimes opioid addiction to another disease. So opioid use disorder compared to just sort of generic lung cancer. There's lots of lung cancers out there, but just put them head to head and we'll talk about them a bit. But with opioid use disorder, if you've never used opioids before, you're obviously never going to develop a problem with it. So you have to have some exposure. Usually, I'd say, I mean, not usually, but In the past, sometimes this was unwanted. So people would say have a car accident or have migraine headaches or whatever, and some doctor would chuck them on a bunch of opioids, and all of a sudden, next thing you know, they're dependent on them, which is really sad. With lung cancer, it's typically an exposure to a chemical like tobacco, but there's other ones that certainly can cause lung cancer. In terms of opioid use disorder, again, you don't go from never using an opioid to suddenly you're full-blown dependent. It often takes months or even years to develop this full-blown dependency that you see. And with lung cancer, you don't go from having one small cancerous cell in your body to full-blown metastatic cancer all over your body. So it takes a while to develop. If you don't treat it, it's fatal if you allow it to progress. So again, whether it's through overdose or an infection of the heart or some other infection of your liver, it can and will kill you. With lung cancer, obviously, if you diagnose somebody with it and you don't treat it, they're going to die from it. Sometimes even the treatment that is used, like the chemo agents, could kill people. Is it treatable? Yes, it's absolutely treatable. So we use medicines to treat it. And of course, with lung cancer, we have medicines that treat it. I sometimes compare going into detox as almost surgery. So you get your surgery, get out the main tumor in your body, and then say you still have cancerous cells throughout. That's more of using the medicine long term to keep it tampered down, and again, not letting it come back with a full force, having going into like a relapse. About 50% of people actually get better with medicine, which is great. Without medicine, the rates are much lower, which we'll talk about. But about 50% of people with opioid addiction, if you get them on medicine, they'll stay very, very stable. With lung cancer, depending on when you intervene, about 50% of people with most cancers actually will survive it, which is pretty neat. In terms of stigma, which is always interesting, so there's a ton of stigma with opioid addiction, and in some ways there's more stigma associated with treating it than the disease, which is a bit crazy when you think about it. So it's almost like we'd rather let it go and not do anything about it than treat it, which is always frustrating, but it is what it is, and we'll talk about it. There's actually very little stigma with cancer, although historically there was a lot of stigma associated with having cancer. So if you had cancer, you wouldn't seek treatment, you just sort of die with it. My hope with addiction treatment is over the years, if you have a problem like opioid use disorder or alcohol problems, people won't feel afraid to seek treatment. So when they seek treatment, they find good treatment that helps them remain stable, which is kind of where lung cancer has gone with oncology. So oncology was more or less a fringe part of medicine. And then over the years, it's really, it's the primary treatment. If you have cancer, I would hope that any of us would go and seek treatment for it pretty quickly. So a little bit on stigma. It's real, it's prevalent when it comes to treating people with substance use disorder. It's a barrier that I often have to overcome. Just convincing people of why or why not they might need medicine can be a task. I think stigma has killed a lot of people, quite frankly, and it will continue to kill people until we get a better hold on it. So there's lots of good physicians, providers, people in general that continue to view addiction as just bad habit or a choice. And when you view it this way, it definitely changes your way you interact with people and how you treat them. I don't think anybody growing up when they're a kid says, when I get older, I want to have an opioid problem, or I want to be found dead in a gas station with a needle in my arm, or I want to be the town drunk and people laugh at me, or I want to grow up and have all my kids taken away because I'm an irresponsible parent. These people again lead a life of suffering. Sometimes they won't admit how much suffering they're in until after the fact, and they look back and they realize some of the things that have happened. But it's a horrible disease. So I like to pose a few questions again, if you're not sort of sold on this whole addiction being a disease thing. I think this is relevant. But what's the closest non-romantic connection two people can have? I'll open it up to the floor. So if anybody wants to unmute, if they're allowed to, Jay, I don't know what you do. If anybody wants to unmute and say it's
I
kind of
don't rule with an iron fist here. Okay, anybody
I
can
don't know,
talk.
Jay. I don't know. You're pretty tough
Yeah,
facts here.
yeah, no, super. I'm very intimidating. No, but yeah,
No.
please
Jay's good.
unmute or use the chat to answer.
I get some interesting answers with the medical sometime. I'm sorry.
I'm gonna say best friends.
Best friend, Anna.
Romantic.
I would. All right. Anybody else? It's not wrong. I guess it depends on how good your friends. I'm not that close to my friends. I'll put it that way. But anybody
Like
else?
a caretaker?
Yeah, maybe. I would say though, for me, parent-child. I mean, fundamentally, I know I have a couple kids, and we don't always have the greatest relationships with our kids, but I don't think you can get too much closer to another human being than if you've literally had that person, live in your body. So like mother, child. Um, I mean, that's about as close as you can get. The very fabric of society, you could argue, is built on family. And so with that being said, what other disease or diseases lead people to choose to continue to do something over having their children? So you're talking about, the disease of opioid addiction or other addictions literally it tears at the fabric of society, of the family, which is to me very frightening when you really just sit down and think about it, that drug use is literally driving a wedge between people and their kids. And I know for you all, this is obviously something you see every day, but it's terrifying to me. It's terrifying that you could go in and you disrupt the normal bonds of family, which it does all the time. And so I would say, who in their right mind would ever choose a drug over their child? And the reality is these people are not in their right minds. So if any rational person that's a loving and not terrible parent is going to say, I would choose my kid over doing this drug or doing that, when your brain is completely hijacked, the decision is a lot less clear. But for any one of us standing back, if you're in recovery or you've never had a struggle with substances, you look and you say, this is ridiculous. Why would anybody ever choose a drug over their kid? But if you think about it more from the side of their brains are messed up, they truly are messed up, it starts to make more sense. It doesn't excuse it, but it makes more sense on why they do these crazy things that we have to intervene with. All right. A little pause on addiction as a disease, because when you say that, often it gets people a little upset. I will say, when you diagnose something as a disease, it does not take away personal responsibility. So just saying it's a disease does not mean that they can do whatever they want and everything's fine. Far from it. So if you have an opioid addiction or any other addiction, you should be expected to, just like any other disease, to seek effective treatment. So if you acknowledge that you have a problem, go get help. Once you get help, you need to continue to get that help, stay in treatment, do what you can, follow guidance by doctors or therapists or whoever. So seek treatment, stay in treatment, help us as doctors to identify any other problems that exist. So, besides, at least from our standpoint, we are interested obviously in people not overdosing and dying, but we also, if someone say has hepatitis C or their heart's messed up, we want to treat that. So we're trying to intervene in other areas in their life, not just get them off of opioids. And of course, you're not, it doesn't give any excuse to break the law or endanger people, including your family. So it being a disease does not excuse, terrible behaviors. I will say though that when people do seek treatment, it's often unavailable or unoffered. So many people are sort of, they're not sure if they want help or not. And once they do decide to get help, say they go to the ER, and then the ER says, well, here's a couple numbers, call on your own, have a nice day. That can be very discouraging for people. So we want to catch them when they're actually interested in treatment and provide them good treatment. Unfortunately, also, when people do receive treatment, they can be pressured to prematurely stop treatment. So some of the worst outcomes I've seen over the years is when people have been very stable on medicines or treatment, and then someone tells them, hey, you need to stop this because it used to be, unfortunately, you were going to keep your kid. You have to stop this medicine or you'll never get your kid back. Or I've had peer recovery people say, everything you're doing doesn't count, you're terrible, you need to stop the medicine right now, or I won't continue to see you as a patient or whatever. When that happens, that's usually when people struggle. Not always, but often people struggle, and you see people go from being very stable and doing well to dead very quickly. And so I just always caution people, if you're going to commit to treatment, do it. And if you decide to come off of it, just do it slowly and carefully and under physician guidance, not because somebody at your AA meeting told you had to stop taking medicine. So, all right, a little bit into opioids and opiates in general. So they all work basically the same way. They work on the brain. Again, they activate those addiction centers in our brain, but they relieve pain on other things. For a long time, opioids were really just used to treat acute pain. People that were dying would get opioids, but no one else really would. We weren't using them for chronic treatment. Unfortunately, in the 90s, things changed with pharmaceutical companies. Again, I hate pharmaceuticals. I hate them with a passion, but they really pushed it to be this vital sign. Pain was a vital sign. The subjective experience of pain became a vital sign. So we had to eradicate pain with medicines. So suddenly we started prescribing a lot of opioids, and a lot of people made a lot of money, and a lot of people have suffered because of that. So there's natural opiates, which is what opiates are technically. Opioids are sort of an umbrella term for everything, but technically, if it's an opiate, it's natural. It doesn't really matter if you say one or the other. Nobody's going to fault you for it. They're often combined with other drugs intentionally or accidentally. So many overdoses you see, people are trying to use, say, cocaine or sometimes even marijuana, and then somebody put fentanyl in their drug, whether it was intentional or even on accidental, because again, drug dealers don't usually just specialize in selling one drug. They sell all drugs. And of course, opioids are responsible for the majority of deaths every year that we have in this country. So a little bit in terms of the epidemic. So we've had more than 1 million people die of drug overdoses since 1999. Before the pandemic, we were at about 70,000, which is a lot. But in 2020, the first year of the pandemic, it went up to 91,000. So that was a 30% increase with COVID. In 2021, it was 106,000. So another 15% increase. And most of the deaths, 106,000 deaths in 2021 were from opioids. So opioids were involved in them, mostly synthetic. So we're talking fentanyl. And of course, if you didn't know it already, but I'm sure most of you do, West Virginia has led the country in overdose deaths, which is a real shame. So what about deaths in this state? So we are definitely more affected than other states. Our death rate, so this is death rate, basically number of people per 100,000, and this is the total number of people that have actually died in each year. We had actually peaked in 2017. We'd hit almost 1,000 people, and then it actually lowered a little bit, so it leveled off. So prior to the pandemic, we were doing a little bit better. So less people were overdosing. It was great. We were really pushing treatments, evidence-based treatments. People were getting better, and then unfortunately, COVID hit. A lot of people stopped going to meetings. Medicine wasn't as readily available. There were a lot of problems, isolation in general. People would be sitting around and you get a check for $1,600 out of the blue, and drug dealers started pushing more potent products at that time. Fentanyl was other opioids actually were less available. Fentanyl was more easily smuggled in the country or made in this country. So we had this huge increase in overdoses in 1 year in our state in particular. So we basically had a 50% increase. In 2021, it went up even higher. This number, if you ever look at a map of overdoses on the CDC, West Virginia has its own color because it's so high compared to other states. So put this in context, California had the most overdoses in total in 2021, so it was 10,000 overdoses. West Virginia had 1,500, but consider that California has 40 million people and we only have 1.8 million people. All right, so if they had our death rate, they would have had about 36,000 people dying in 1 year. So I always say, when little old West Virginia loses 1,500 people in a year, which is basically 1 out of every 1,000 people in the whole state, nobody thinks twice about it outside of our state. We obviously care, but on a national level, West Virginia lost 1,500 people, no big deal. If California suddenly had 36,000 people die of overdose in a single year, folks would be going nuts. You would see so much money pour into there, so much treatment be available. It'd be amazing. But again, our state is underrepresented and we need to really stand up for ourselves. So again, besides overdose, which is the most drastic thing you see is these overdoses, there are other things that happen. So of course, if you have hepatitis C, that's rough. HIV, if you get an infection of your bones or your heart, or the criminal component. So let's face it, if you're dealing drugs, you are a criminal. People die in drug deals gone bad. Smuggling is illegal. People die every day at the border. These are real things that we deal with. So we think a lot about overdoses, but it affects society in many different ways. So what about treatment options? So we know we have a problem. How do we treat it? So unfortunately, some people would propose we don't do anything. So we let them die. After so many overdoses, we tell the paramedics to stand back and watch somebody overdose. I trained as a paramedic. I worked with paramedics. If some politician told me to go, respond to an opioid overdose and then watch somebody die in front of me, I couldn't do it. So that's unethical. It's terrible, and I'm sure most politicians wouldn't argue that if their son or daughter or grandchild had an opioid addiction. So we're obviously not going to choose option number one. Detox only, this really doesn't work. So if you send somebody to detox from opioids and then kick them out after 6-7 days and pat them on the back and say go to meetings and enjoy your life, most people struggle, and it's not really even considered a medical treatment anymore. We'll talk more about it, but it's basically malpractice when you do this. If you detox someone, then send them to a 28-day program, residential treatment, rehab. This does sometimes work, but the failure rate is still pretty high. So rehabs now are moving towards using medicine because they have such better outcomes. So places like, most people are familiar with Betty Ford in the clinic. They fully embrace medicine now because their outcomes were so poor with people recovering from opioids. If they just did the standard detox, residential meetings, cut them loose, it really rarely works. Some people are an exception to the rule, and it's great if they do okay without medicines, but most people will struggle. So the reason we use medicine is because it usually works. So about 50% of people on medicine are not going to use opioids anymore, which is great. And about 75% of people will actually stay in treatment. So they might still be struggling a little bit here or there. They might have relapses from time to time, but they're alive and they're seeing you. And that's something. That's something. It's, if imagine your doctor, you had cancer and you went to your doctor and he said, well, we can try this treatment, but you have only a 5% of success. I don't think anybody would choose that. If your doctor said, you have basically a 1 out of 2 chance to do well, you would choose that. So that's why we do it. So the bottom line is we use these medicines because they work, not because we're trying to make money or keep people strung out or whatever it is. I certainly don't, but we use these medicines because they work and they keep people alive. And that's a lot. There's something to be said for that. So what about the medicines that we use? There's different ones. It is the gold standard of treatment for opioid addiction. So it's really the only efficacious and ethical medical treatment available. So it's the only ethical thing we can do as doctors is to prescribe medicine if we're treating opioid addiction. Everybody recommends using them. So ASAM, I mentioned them, kind of part of that. So AAAP, NIH, SAMHSA, so the feds, AMA, everybody feels that this is the right thing to do. It's a consensus now, not just in this country, but across the world. If somebody has an opioid addiction, you should use one of the medicines that is available. Full stop. If somebody's pregnant, it's always recommended they stay on MAT, never detox. It's just a fundamental thing that if you're trying to hurt the pregnant woman and their child, you could detox them, but we're not trying to injure anybody. So they recommend that you keep them on medicines. You try to keep them stable. If you keep mom stable, baby's going to stay stable. So there's 3 medicines that we use. They're all considered first-line treatment for OUD. So methadone has been around for a long time, unless we forget it's helped many, many people over the years. Naltrexone, which we'll talk about a bit, and then buprenorphine, which most people think about when they think MAT. But again, the primary goals of treatment, why we use these medicines, are we don't want people dying, and we want to give them back some of their life that they've lost through addiction. So the principles of using medicine effectively, and just so you know, I think we're going to make these slides available if Jay lets us, but you guys can review these on your own later. But again, using medicines is the gold standard of treatment. The choice of what medicine we use varies person to person. Their personal preferences, insurance, logistics. Do they live near a methadone clinic? Are they, in the middle of nowhere? It can change things. If we detox somebody alone, this is not considered a treatment anymore. This is essentially malpractice. So it's not recommended to do this unless you're trying to hurt somebody. From a clinical point of view, if someone's taking these medicines as prescribed, that is sobriety. And again, I mentioned pregnancy, but it's maintaining people specifically on buprenorphine or methadone is what's recommended in pregnancy, not detoxing. And not treating opioid addiction, for instance, in prison. When people are released within 2 weeks of leaving prison, they're 129 times more likely to die of overdose. So this is just kind of a sample of why we use medicines, because when people go to prison, they lose their tolerance, they get out, and then bad things happen. So there's a big push now to provide jail. Good. Man, I think your phone's on. All right. A little bit in the medicines themselves. So there's methadone, which is a full opioid agonist, very similar to other opioids that people may use by prescription or even illicitly. There's naltrexone, which is an antagonist, a blocker, very similar to Narcan. And then there's buprenorphine, which sort of lives in the space between, it's partial agonist. So some of the good things with methadone is it's been around for a long time. It works very well. It reduces overdoses, which I mean, again, we're dealing with a lot of overdoses, so why not use something that works well for overdoses? You could argue it's probably the strongest treatment of OUD that exists, because again, it's been around for a long time, and it most closely mimics the effects of full opioids. With buprenorphine, the pros is it also reduces overdoses. So people on bup are less likely to die of an overdose than people that are not in treatment. In terms of overdose from the medicine itself, it's very hard to overdose on buprenorphine unless you combine it with, say, sedatives like alcohol or benzos or barbiturates. It does help with pain. It's pretty easy to get people on. And again, I mentioned there's these new long-acting forms. In terms of naltrexone, there's the extended release form that's given. It's not diverted, so that's a nice plus. There's no risk of overdose from the medicine itself. However, if it's not, let's say you took your shot and it's worn out of your system, then you have a risk of overdose, if you don't stay adherent to naltrexone. And sometimes people can overcome the effects of naltrexone by just using an insane amount of opioids. There's no dependency to naltrexone, so you can come off of it if you want. And there tends to be a little less stigma if you're on, Vivitrol. Problems with methadone, it's very inconvenient, so you need to get it from an opioid treatment program. There's only 9 in the state, which makes things very difficult. There's possible diversion. It's potentially lethal in overdose. So if you take too much, it will kill you. There is a withdrawal from it, and there is stigma with it. In terms of cons with buprenorphine, so among other things, there is stigma with it. So people being on Suboxone tend to have problems. There can be withdrawal if you stop taking it. So we don't advise people to suddenly start and stop their medicine. And there's not enough people that prescribe it. Of course, diversion. Problems with naltrexone is the compliance tends to be very poor. So people will get one shot and then never take another shot of Vivitrol, which again, what's the point never giving it to begin with if people don't stay with it? It's very difficult to get people on it. It doesn't reduce overdoses. So from a population standpoint, being on naltrexone is not a good treatment if you're trying to lower overdoses in your area. On an individual level, it can certainly help. But compared to buprenorphine and methadone, it doesn't have overdose reduction. It's interesting. It doesn't help with pain. It's expensive, and cravings, it's a question mark. Some people feel better with it. Some people, it does not help their cravings as much.
Hey, so, Jeremy.
Yes, I know I'm going late.
No, that's it. No, there's actually a question. There's a question in the chat about the difference between agonist and antagonist.
Okay.
Can you explain the difference of those?
Sure. So a full agonist, I'll try to keep it short. Sorry if this gives anyone flashbacks of biochemistry. So think of your think of your brain and the receptors in your brain, like the opioid receptors, as being doors. So an agonist, the way it works is, imagine, you go to the door and the agonist fully opens the door. So it lets everything in. It lets in all the feel-good hormones, but also the potential for, say, an overdose by lowering your respiratory rate. An antagonist is where it goes to the door and it guards the door. It keeps the door locked shut. In the case of something like Narcan, what it actually does is, imagine it goes to the door, which is open from the opioid, and it slams it shut and keeps it shut for a little while. So naltrexone blocks the door. Buprenorphine, a partial agonist, it basically, it's like you crack open the door, you leave it open partially, so you let in some feel-good hormones, but not to the extent of a full agonist like methadone or fentanyl or roxycodone or whatever it might be. So it's a partial agonist. It does some things like methadone, but it also does some things like naltrexone. So it blocks other opioids. It actually prevents you from overdosing. So you can imagine it lives in that space in between the two. Sorry if I wasn't more clear. All right, moving right along. If we go late, we'll blame Jay. What if we could use long-acting injectable implantable buprenorphine? So this is, a great idea and potentially huge therapeutic benefits. So what are the benefits of it? So if you could give a shot of buprenorphine instead of the films or the tabs, of course, that's going to eliminate diversion. So you can't take the shot out and then give it to somebody else. There's no risk of IV use from the shot itself. You can avoid taking something daily, which sounds great. And is there a smoother course of the medicine / withdrawal? Perhaps. More accepted, hopefully, less stigma. Is it the ultimate opioid addiction cure? What are the problems with it? It's expensive, very expensive. Unless you're independently wealthy, no one can afford this out of pocket. You have to have insurance to be able to pay for this. There are side effects from it, especially from giving shots. The injections, we've had some serious problems with people who have had the injections. The adherence is not great, so people will get one shot again and then maybe not show up again because they think they're cured. It can be difficult to obtain and administer it, so there has to be special training. The DEA puts a lot of barriers in terms of how to get. It's unfortunately being very heavily advertised by big pharma. So this always scares me. If they're really pushing for something, then you really want to take a pause and say, is this the best idea right now? And does it provide kind of a false sense of security and stability? So we've seen all these things, both from a pro side and a con side using these ones. So the long-acting options that we have, so one that doesn't actually exist anymore, but it was called Probufene. This was an implantable rods that you had in people's arms. So this was used for a few years and then taken off the market, not because it didn't work, but basically because they didn't sell enough of it. So you may or may not see this pop up again in the future where there's actually implantable, surgically implantable rods. Think like Nexplanon for birth control kind of thing. Sublocade is what we do have right now. And so this is an injection that you get once a month. So it gets put under the skin, not the muscle, under the skin. So it was approved in 2017, and West Virginia Medicaid has really only covered it for about the last 2 years. So for a few years, we had very limited access to it, but now we have more access to Sublocade. Brixadi is the newest one that's just been approved. It's very similar to Sublocade, although it has weekly and monthly forms, so it's a little bit different. It was initially used in Europe, and it was approved in the US in May of 2023 and just became commercially available in September. And some private insurances will actually pay for it right now, Peak being one of them. West Virginia Medicaid, we're working on them, but the hope is that it should be fully available by January of 2024. So we'll basically, as of the start of next year, we'll have 2 different shots available to offer folks. Now, some keys with using injectables. This is an alternative to daily dosing with films or tabs. It can eliminate some of these issues that we have with sublingual in terms of side effects, not talking diversion, but there are problems with the films and tabs, so dental problems, nausea, intolerances to them, but it remains very expensive and it's nearly impossible again to receive if you have no insurance. It's not offered at all at all clinics, and the DEA has made things very difficult for us to administer it. Many people in our clinic, we've tried to switch them from being on films for a while just because they wanted to switch to the injectable, and it hasn't always gone well. So I've sort of changed my way of thinking that the injectable seems almost work better on people that are new to treatment rather than people that have had been long-term stable on films. So it's being marketed a little bit too much, I'd say, where everybody should be switched to it. It's a good tool, but it's not this cure-all. So I always say be wary of the heavy marketing used by pharmaceuticals. So they stand to make a lot of money off this. And again, there's nothing wrong with the medicine itself, but the way it's being advertised is a little concerning. And I always say the decision to use these meds should be really a shared one between the patient and whoever's prescribing it. I would just caution against forcing someone to switch the shot, because asking someone to take an injectable of this medicine, especially when I've seen some of the things like wounds opening up on their stomach, or again, people that are very reliable, that have been in treatment on films for years and done great, suddenly struggling mightily with the shot. So it's, I would just caution against saying, well, you need to be on this, you need to be on that, because that's where problems can arise. We're almost done, I promise. Common myths on opioids and treatment. So the old idea that, you could put somebody in rehab for long enough and that was the gold standard of treatment. Of course, that's not true anymore. Rehab is a good tool and it's a good foundation for people, but really medicine is what the gold standard is now. People are cured of their opioid addiction after a few months of sobriety. Not true. Again, we can contain it. We can't necessarily cure it, but we can contain it and help people to live with it. Addiction is not a disease, simply all choices. Again, I hope you realize that. I think there's a little more to it than that. There's certainly choices involved, but long-term use, it becomes a full-on brain disease. It's easy to contract an infectious disease or overdose if you, as a layperson, are exposed to drugs and or drug paraphernalia. So this was a thing going around that, if you're in the same area as someone that used drugs and you look at them, you might overdose. And a lot of law enforcement were buying like these mobile vans and helicopters and tanks to, if there's fentanyl, and a lot of that's probably unnecessary, quite frankly. So if you're overdosed, exposed to fentanyl, it'll kill you. Yeah, not really. I mean, if you're like snorting it or, get a lot on your hands and like licking your fingers or so, I don't know, but it's not plutonium. It's not uranium. It's not quite that deadly. Fentanyl leaves the system as quickly as it enters it. Not true. Lots of people, it stays in your system for a long time. So there's some evidence that it stays in there for at least upwards of 3 weeks, fentanyl. So one of the problems we've had is people, go into treatment, they leave treatment, they keep testing positive for fentanyl, but levels are coming down, but they get in a lot of trouble and they really haven't used anything. It's just taking forever for it to clear the body. There are no substances that can give false positives. Not true. We'll talk about that a little bit. And no one ever gets better, which is not true, because many folks are in recovery. And quite frankly, that's why I do what I do, because I like to see people get better. All right, so a little bit in best clinical practices. Again, using medicine is the clinical gold standard. If you ask an ethical physician to detox someone, you're asking me to commit malpractice, so I won't do it. Unless a patient tells me to do it, that they refuse to take medicines, but I'm not going to do it willfully, put it that way. Beyond just best clinical practice, again, now things have changed where the Department of Justice has said that this is a disorder and it needs to continue to be treated. So I'm sure most of you have seen this from last year, but it's a whole thing that people are protected if they have an opioid problem. So they're actually protected under the Americans with Disability Act. So the basics of this is that it's a disability. If someone's being prescribed a medicine for opioid use disorder, you can't take it away unless they're abusing the medicine they get or if they're abusing other drugs with it. But there are some protections against taking away. So I'll leave this. You guys can read it on your own, but that's from the ADA. In terms of drug screening versus confirmation, I always encourage folks to, a screen is just a screen. The confirmation is honestly more important in many ways. So a screen showing that someone's used a drug is often can be misleading. So sending it off for confirmation and knowing how to interpret the results is really important. So false positives happen, false negatives happen. I say I try not to make any major decisions on people clinically until I have, actually confirmed results. So we should definitely do screening, but again, take it with a grain of salt. We want to do definitive testing, so sending it off to really make sure that our screens are accurate. And so it's good, it's necessarily, but try to avoid making major decisions based on just screens alone, unless somebody tells you they're using. If they say, yes, I've been using, and yes, it's in the screen, then that's enough. But if someone assures you, hey, I have not been using, just caution making too many major decisions until you understand it. So a little bit of false positives. You can just know that there's lots of over-the-counter things and prescription medicines that can cause these. And I would say actually a false positive, you could think of it as a worse outcome than a false negative. So if someone, screens and it shows a drug that's not actually there, and then they get in trouble, say they lose their kid or something. That would be worse in a way than, let's say, they had a false negative, because a lot of times a false negative, someone kind of got away with one, you could say, you'll eventually find them out. You'll find out that they're struggling. But false positives, if you're kind of guilty until proven innocent, that's more dangerous in a way. So again, false negative, you might get away with it for a little bit, but a false positive, making a decision based on a false positive or kind of a questionable result, that could mean somebody goes to prison or loses the kid forever. So just be really careful. Or for fentanyl, for example, there are false positives, including trazodone, which many people take, probably some of us take, Risperdal, Invega, Fanapt, and even Benadryl, in theory, could cause a false positive on fentanyl. So just be really cautious. This is another table of just things you can look at, but things like testing positive for benzos, Zoloft, that's the most common antidepressant prescribed, and that can test positive for benzo. Amphetamines, over-the-counter cough medicines like pseudoephedrine, phenylephrine, phentermine. So my Alka-Seltzer cold and sinus, if I took that and then did a drug screen, it might show up as amphetamine. I don't want to lose my kid over it. So in conclusion, so substance use disorders affect many individuals, especially, of course, people in the justice system. Our state is hit hardest, so we definitely need the best treatments and standards of care available. This is considered a disease, but it does not diminish the consequences of use. So again, people use, we're not excusing their use, but it helps us to understand why they do the things they do. It is the gold standard of treatment for opioid addiction, and it's very effective if used properly. That's why we use it. The DOJ does consider opioid addiction a protected disability. So preventing someone from getting it, you're violating their civil rights. So just proceed with caution. There are these new options available, which we should really expand, not restrict treatment. So again, I don't want anyone to take away from this that the shots are great and we need to put everybody on shots, because if we did that, quite frankly, we'd probably bankrupt Medicaid and no one would get any shots. So for the right person, the right situation, the shots can be very effective, but the shots are not meant for everybody, nor should they be. And I always say, working together, just as a group, we can accomplish more than if we're trying to kind of do our own thing. So I appreciate everybody. I'm sorry that we went a little bit long. I'm going to blame Jay, but I know it's not his fault. So he's a good guy. Just kidding.
Thanks, Dr. Houston. That was great. I mean, you'll never come back, but it's fine.
One and done. That's
it.
Yeah. Does anybody have any questions? I'm sorry if I went over time, but again, it's a big topic. Okay. I've taught residents and fellows, and we'll spend hours and hours going over this stuff. So it's hard to condense down into 30 or 45 minutes, honestly. So who has questions? I'd be glad to answer them. And I think we'll make the slides available too. So
yes.
You and on the slides, my office number and my email are on there. So I've had people reach out to me before. I've actually done some trainings at like drug courts and gone and just done free trainings and sit down with people and kind of go over things. Sometimes running through cases can be helpful too. So.
Yeah, I just, Dr. Houston, I really appreciate you presenting, the pros and the cons. So there is no medication that's appropriate for everyone. Although this is in terms of the research, this is a medication that is really, really helpful for a lot of people compared to even other medications like antidepressants or antipsychotic medications. Like this is actually a really, these three medications, and specifically methadone and buprenorphine are really, really helpful for most people. We acknowledge misuse and diversion risks, and we talk about with our patients all the time. And so it's just a reality of being on certain medications. And so to have that be part of the conversation versus like, this is bad because it has this potential.
Yeah.
I think it's important to consider. And there's still, there's lots of stigma. There's community-based stigma. As you said, there's like kind of patient stigma or recovery community-based stigma. We're working to help people have accurate information to make good decisions for them.
I like to sometimes think, like, let's imagine we all jump in a time machine in 10 or 15 years and we look back at the things we're doing today and see if we could have done things differently. I will say our future selves are going to ask why we didn't use more of these treatments right now. I mean, even, the last 10, 15 years, it's changed a lot, but the concern is that we don't use them as much as we should. And definitely people are dying because of that. I think we'd all agree with. And so, anybody have anything specifically they want to ask? And I'm willing to stay on a little bit afterwards too. I don't have anything. If anybody wants to just ask some questions, I'd be happy to. Or again, call. That's my office phone. There's a voicemail on it, and I'll return your call. I try to be pretty good about that. So. All right.
Yeah, I think we'll stop at 11 here, keep everybody on time, but thanks again, Dr. Husted. Yeah, we will send out the slides, the recording. Please feel free to reach out to him directly, or if you need, I can be the conduit as well. We'll see you on the next session, which is on the 15th of November.
Thanks, everybody.
See ya.
See ya.
Thank you.
Stay well.